Hello, welcome to chapter 23, where we're going to talk about the cardiovascular and lymphatic system infectious diseases. So this is kind of a long chapter, so we're going to split in some parts to make it easier for everybody. So the first thing that we're going to do, as always, is look at our learning objectives. So this is so we have bacterial diseases, and then, so these are all bacterial diseases. And then we're going to move to viral diseases and protozoan and helmintic diseases. So first video, this one, we're talking about functions and structures of the cardiovascular lymphatic system and the definitions and how septicemia, sepsis, and septic shock work. Also about heart infection and rheumatic fever. And then we move on to the other bacterial diseases in the next video. Alright, so starting with the cardiovascular system. So remember that it includes the heart, arteries, veins, and capillaries, right? So when we think about it, and you have the heart pumping blood to different places, to different organs, and as it's pumping, the blood goes through arteries. So whatever goes away from the heart, you call it arteries. And then when they start to branch, they're called arterioles when they get thinner. And arterioles branch into what you see in purple here, which are the capillaries. The capillaries are basically a layer of epithelial, which are what we call endothelial cells. And that layer is super important for exchange of substances between blood and tissue, whatever the tissue is. If it's a tissue that needs oxygen, as all our tissues in our body, you unload oxygen and nutrients to the tissue, and you load back to the blood, for example, the waste and the CO2 that are going to circulate and go back to the lung or the liver, whatever the case of what you're trying to eliminate is. So for example, CO2 would then run back through venules in the blood, right? Venules, veins, and back through the vena cava, which is the thickest one here, and back to the heart. And then the heart pumps it to the lungs, right? Through the pulmonary arteries, which are these ones. So the pulmonary, told you wrong, which is this one here. This is going to the arms and to the head. That's the superior vena cava. The pulmonary arteries are here, coming from the right ventricle, right? So this blood that is being pumped now to the lungs is loaded with CO2, and you want CO2 to be unloaded in the alveoli to be exhaled, right? And eliminated. All right. So with this, you have an idea of how circulation worked, and we went into this much deeper when you had A&P, right? The lymphatic system is a system that runs in parallel with the cardiovascular system. So remember that the lymphatic vessels also end in lymphatic capillaries, and these capillaries for the lymphatic system are close to the capillaries for the cardiovascular system. The difference is that these capillaries are blunt. They're not looped into like arteries and then capillary and vein. In this case, it's like they're just blunt. They have like a, let me see if I can draw here. They have a get the pen, hold on. A blunt end, right? And that's what's going to branch up into more into lymphatic vessels. So this is the lymphatic capillary, right? So what happens here? This is in the tissue, right? So let's say this is the tissue, and you have lymph, which is fluid that came from the blood. So this is a capillary here, right? This is a blood. Oops. This is a blood capillary. The blood leaks to the tissue, right? The water from the blood, the the chemicals, the salts, some proteins, they leak some cells, right, during inflammation, if it's a case. Everything leaks to the tissue. And that because of, remember, you have osmotic pressure and hydrostatic pressure, which press the blood against this thin capillary wall that I told you that is made of one layer of cell. So you have all this fluid here in the tissue, right? Tissue. What happens to this liquid? Some of it drains back to the blood. But there are some 3 liters per day of interstitial fluid, interstitial meaning in the tissue, right? That doesn't get drained back to the blood for physics reasons. So somebody else needs to capture this 3 liters per day of fluid that is in the tissue and bring back to the blood. And who does it? The lymphatic capillaries. Okay, so then they receive back these 3 liters of fluid. And if we go back here to our cardiovascular system, the lymphatic vessels are like here, right? And they're like here, and they're going to dump it back into the veins. And then it goes back to the blood, right? So that's how, so the lymphatic system is from tissue up to the vein, to the jugular vein. And it doesn't go, actually I think it's not the jugular, it's the subclavian, and that would turn into jugular. This is just a one-way flow. So it doesn't flow back anywhere. It's always from the tissue to the vein, okay? And in this process, of course, in the middle of this, what do you have? You have lymph nodes. And in the lymph nodes, remember the immune system is where, for example, some bacteria that was in the blood that leaked to the tissue, or that was in the tissue and leaked to the lymphatic system, is going to be presented through APCs, antigen presenting cells, to our lymphocytes. So that happens in the lymph node. So in this flow to the from the lymphatic system, you meet lymph nodes. So all these little bumpy areas here are lymph nodes. And that's where the presentation of antigens, of pathogens, happens. So other than draining the fluid, they also help with the immune system function of recognizing antigens that we need to attack. Alright, so now we're going to talk about sepsis. What is sepsis? I'm going to read here so it's really clear for everybody. Sepsis is when germs get into a person's body and cause an infection, right? So that's the initial thing. If that infection is not stopped, then you have sepsis. Why? Because that initial infection, that local infection, can become a focal infection, which is when that, those bacteria that are present in that area can migrate to a secondary area and cause a secondary local inflammation. So that's what we call focal inflammation, the secondary, the tertiary inflammation that came from the initial one. It is known that nearly 270,000 Americans die every year as a result of sepsis. Okay? 1 in 3 patients who die in a hospital setting are the cause of death is sepsis. 1 in 3. It's a huge number. So sepsis is a very important condition that leads to death. Okay, so that's why we're talking about this with a lot of relevance. So what is involved in sepsis? It's a very severe inflammatory response to infections, the systemic inflammatory response syndrome that happens as a consequence or as part of the sepsis is called SIRS, okay? And what comes with SIRS? High heart rate or low blood pressure, fever, shivering, confusion, disorientation, shortness of breath, extreme pain, and clammy skin. If this persists, you can have a very severe drop in blood pressure, and that would cause to dysfunction of at least one organ, right, in the body. So when at least one organ is dysfunction due to sepsis, you call it severe sepsis. Okay, so it's starting to affect your organs. You don't have enough blood pressure and flow to bring oxygen and nutrients to the tissues, and that's when you start to have seeing these organs fail. Okay, and then when severe sepsis is uncontrollable and it causes an even more severe drop in the blood pressure, then you call it septic shock. Just to clarify, septicemia is an acute illness, which septicemia is not sepsis, okay? Septicemia happens when you have growth of pathogens or their toxin in the blood, okay? So the fact that the microbes are in the blood present and growing, that's what you call sepsis. So if I say microbes are present in the blood, how do you call that? That's called bacteremia. Microbes are present in the blood and growing and proliferating. That's what you call septicemia, okay? Just one more image to make sure sepsis is clear. So I told you that from the focal infection, so this here would be the focal infection that came from, let's say, an initial local. Let's say the local infection caused the focal infection, right, in another tissue or another part of the tissue. These bacteria that are growing here are dumping their toxins, parts, shedding parts when they die into the blood. And that's causing the blood cells to get activated, right? And some of them, of course, are also going to move to the focal infection as a result of the inflammation. These will lead to leaky vessels. Remember histamine, bradykinin, all the substances that allow the blood vessels to be more open, the capillaries, and then you leak fluid to the tissue, right? And formation of clots. These can start to cause inflammatory response throughout the body. So this is sepsis, okay? Sepsis happened because initially you had that syndrome, SIRS. So what is SIRS? If you say, okay, what do I need to see, to look for in a patient to say the patient has systemic inflammatory response syndrome? Temperature, high heart rate or respiratory rate, different abnormalities in white blood cells numbers, and pressure of CO2. Okay, so 2 of this list plus confirmed or suspicion of infection is what you call sepsis. And then for that to become severe, what do you need? At least one organ with damage, some hypotension, and then there's lactate too that I don't focus so much on, but that's another parameter that you can see. And from severe sepsis to become septic shock, you need persistency of the sepsis, signs of organ failure, even more critical and prolonged hypotension, and then septic shock can cause death, right? This is kind of cute. So if you have already an infection in skin, lungs, or urinary tract, that will trigger your reaction through your body. That's sepsis. Skin, lungs, urinary tract, or somewhere else. Trigger a life-threatening chain reaction through your body, and that's sepsis, okay? Another sign that you can see in sepsis, because the lymphatic system is involved, is lymphangitis. And lymphangitis is when you have inflammation of the lymphatic vessels, because bacteria are also present there, and you have all this flow of immune cells, and that inflammation can be seen through the skin. So wherever you see the rash on the skin is a lymphatic vessel underneath it. And this is a sign that there is something not good going on in the body, okay? Sign of sepsis. All right. So now we have two different types of sepsis depending on the etiological agent. If it's a gram-negative bacterium, you know that gram-negative bacterium produce LPS, right? So the LPS produced here is, remember, when the bacteria are growing, they shed LPS because it's in the cell wall, or when the bacteria are dying, that cell wall that gets broken up has LPS, and that's what's going to trigger the sepsis, and I'm going to show you how. First, which agents are related to gram-negative sepsis? Klebsiella, E. coli, Pseudomonas. These are the most frequent. Okay, remember Klebsiella and E. coli are Enterobacteriaceae. Okay, so they can be involved in that process. One way that LPS works to cause sepsis is because it can change its structures, be transformed by the bacteria, like small modifications in LPS, make that bacteria evade the immune system recognition, and then the bacteria can grow more, okay? So how do you treat this? You need to use some kind of substance that neutralizes the LPS components and the cytokines that are causing that inflammation. So this is one diagram that explains to you how endotoxin is potent, right? So they can activate PAF, causing blood clot, and DIC, which is disseminate intravascular coagulation. They can also trigger complement and cause inflammation, and that inflammation can, if it's very exacerbated, lead to shock. You can also have leukocytes being activated through LPS, and then they release cytokines, so they can release TNF, alpha, and IL-1 and cause fever. IL-1 can also release neutrophils that will dump even more cytokines in and damage the blood vessel walls, and other interleukins that can do the same thing, like interleukin 6 and 8. That will cause all this damage in the blood vessel wall, will cause plasma loss, reduction of blood pressure, shock. Okay? Shock is like your blood is not even moving enough. How can your body function, right? So that's gram-negative sepsis. If we think about the gram-positive sepsis, then remember that there are exotoxins produced by gram-positive bacteria, and those are going to be the ones responsible for the effects, right? Remember that other than some exotoxins are actually super antigens. I'm going to write here because this is important. Super antigens are also going to be very important in triggering this effect, okay? So you have Staphylococcus aureus, Streptococcus pyogenes producing very important toxins that are considered super antigens. So what super antigens do? They cause an exacerbated response. They cause an exacerbated production of cytokines by immune cells, and that's that intense response that is triggered is very likely to lead to sepsis, okay? It's a response from the immune system that is not desirable, okay? Kind of like if you think about an allergy, not wanted. This response by super antigen is not wanted, okay? So Enterococcus faecium and Enterococcus fecalis are bacteria that are present in our column, Enterobacteria. They, forget what I said, they're gram-positive bacteria that are present in the column. Not Enterobacteria are gram-negative, right? So this is gram-positive. And they can also colonize wounds in urinary tract, so they're related to nosocomial infections. And they can be, because they are nosocomial, they're used to the environment in the hospital, they can be resistant to many antimicrobial drugs. Enterococci are the third most common nosocomial bloodstream pathogen and are causing agents that cause intra-abdominal infection, genitourinary, surgical one, endovascular, and other serial infections, okay? Another bacterium that can cause gram-positive sepsis is the group B streptococcus or Streptococcus agalactiae. This causes neonatal sepsis, okay? So this is common in the baby right after birth because of this bacterium. The baby still doesn't have enough immune system response, and then they can get severely impacted by an infection like this that happens during birth. Also, the mom can have issues, and that's what we call puerperal sepsis. So the mother, after the childbirth, can be infected by Streptococcus pyogenes because of that exposure that you have during the birth, right? So it infects the uterus and progresses to an infection of abdominal cavity. That's what would lead to sepsis, okay? Because it takes over the abdomen. 1 to 8% of all births, not just related to puerperal sepsis, but 1 to 8% of all births have as risk factor the C-section, because it's an incision in the body. You're using instruments. You're invading the body through that procedure, right? And that is one way that this can happen, okay? So risk of infection during C-section are a big thing. That's why doctors push so much vaginal delivery. That could have other issues, but not this one. In general, there is 13 in 100,000 maternal deaths in the United States. But that's not only related to this condition, related to any general condition. So 13 in 100K, it's a number that you need to think that delivery is not a simple thing, right? It needs to be thought and it needs to be planned. The heart can get infected. If the heart gets infected, you can infect one of the 3 layers of the heart. So let's say this is your heart here, right? That's the heart. You have a muscular wall, right? So that's the muscular wall. The muscular wall is the myocardium, right? The endocardium, so let's say these are the 4 chambers. The endocardium is the layer that lines the inside of the chambers. So that's endocardium. And then you have pericardium, which is that sac. It's a double layer sac that surrounds the heart. Okay? So that's the pericardium. So you have a sac around it, a muscle on the wall, and an endothelium inside. These 3 layers can get infected with bacteria. Okay? Endocarditis is the one that we focus more on because it's an inflammation that usually involves the heart valves, more even the inside of the valves, even more than the ventricles or atria. You can have subacute bacterial endocarditis caused by alpha hemolytic streptococci from the mouth. So, if you don't treat a local infection in the mouth, those bacteria, usually Streptococcus mutans is the one that you see in the mouth, can go to your bloodstream and migrate through the blood to your heart and cause a heart valve infection. Okay, that's endocarditis. You can also have acute bacterial endocarditis caused by Staph aureus from the mouth. Remember, they're normal microbiome from the mouth. But if they get into your bloodstream due to bad hygiene, gingivitis, periodontitis, anything that is exposing your blood vessels in the mouth can lead to that. They have a tendency to migrate to the heart, okay, and to the heart valves. Usually there is an obvious infection in the mouth, so it's not something that goes unnoticed, and it would cause abnormal heart rate and embolus can also block blood vessels in other organs, which is another complication. Myocarditis, so it infects the muscle of the heart, that can lead to heart failure or arrhythmia because the heart muscle starts to contract in the wrong way or not enough. And pericarditis can be caused by streptococcus, also that can come from the mouth, okay? Prosthetic valves, immunosuppression, medical intervention can all result in this condition, okay? That should say pericarditis, not endo. This is how it looks when the valves or the endothelium of the heart is infected, okay? The normal appearance would be this. You see these little cords are like the little tendons from to open and close the valves, and then look how swollen and gooey and full of clots the tissue looks when it's infected, okay? Rheumatic fever is another disease that is important because it's also a complication of an infection either in the throat or another disease that is called scarlet fever. So these two diseases, strep throat that could develop into scarlet fever, which is a Streptococcus pyogenes that has an extra toxin and that causes scarlet fever instead of pharyngitis. These two diseases can lead to an autoimmune complication. So why? Remember, Streptococcus has M protein. So the streptococcal M protein, you start to have an immune reaction to that. And then you have, let's say this is the M protein. That's the M protein. And then you start to make antibodies against them. So everywhere you have M protein, you make antibodies against them, right? And this is what we call immune complexes, right? Immune complex. These immune complexes start to accumulate in joints and in the legs, for example, in the heart, in the skin, and that causes the rheumatic fever. So you start to see nodules, kind of like this one. You see, this is the elbow, and that's a nodule formed by deposition of immune complexes. Okay, the symptoms of this disease are usually fever, pain in the joints. They become tender. Most commonly knees, ankles, elbows, and wrists, where you have joints, right? You can have congestive heart failure that includes chest pain, shortness of breath, fast heartbeat, fatigue, and some jerky, uncontrollable body movements. That's accompanied by this disease too. There is also a rash that can appear as rings, pink rings with a clear center, but this is a rare symptom, okay? And this can all start with a strep throat. So strep throat needs, if it's detected, mostly in kids and elderly patients, you need to treat it before the bacterium can migrate, to your body, and then you start to have those immune complex depositions, and it worsens what started with just a sore throat, right? So usually rheumatic fever can happen 5 weeks, 5 weeks after a strep throat or scarlet fever. All right, I am going to stop this video and I'll come back to talk to you about the other bacterial infectious diseases, okay?